Hi, everyone. Today's question is very straightforward. He is a 65-year-old man with history of liver cirrhosis who came into the ER with hematemesis. The patient has been seen in the ER. His medication history includes Lasix, Aldactone, and he was on salt and water restriction for the history of ascites. He has a history of varices and bleeding, and 4 months ago, he has band ligation. When he came into the ER, his temperature was 98.6, blood pressure 89 over 59, heart rate 121, respiratory rate 19. His abdomen was distended, but not tender, and there was positive shifting dullness uh, and normal bowel sounds. There is two pedal edema in the lower extremities. His hemoglobin was 8.2 grams, white cell count 7,500, BUN 65, creatinine 2.1. Patient received IV fluid. However, his urine output continues to decline, and his creatinine went up to 2.8. The FeNA was less than 1%. Urine dipstick was negative for protein and the blood, and there was no evidence of active urinary sediments. And now, what would be the most likely cause of this patient acute kidney injury? Is it hypovolemia, interstitial nephritis, HRS, ATN, or glomerular disease? And most of you guys got the right answer. The right answer is HRS. And here is the teaching points. HRS is an important complication of end-stage liver disease and liver cirrhosis. And patients with HRS usually have AKI with very low urine sodium. Usually it's less than 10 with FeNA less than 1%. And absence of blood, CAS, protein in the urine, and renal function doesn't improve after IV fluid. This patient, he could have hypovolemia as a differential diagnosis because hypovolemia also is associated with low urinary sodium and low FeNA, but this patient did not respond to the IV fluid resuscitation. ATN usually cause higher urinary sodium and higher FeNA. And of course, this patient doesn't have active GN or interstitial nephritis because the urine analysis was bland. The onset of AKI and HRS is usually insidious. It can have abrupt worsening of kidney function with acute insults or precipitating factor. And in this case, the precipitating factor was GI bleed. The diagnosis of HRS is usually done after excluding other causes. And we have to usually exclude hypovolemia, ATN, interstitial nephritis. And I will stop by here. And thank you so much, everyone who contributed and tried to answer and learn.